Okay. Good afternoon, colleagues who've joined us today. This is our Bedfordshire Luton Milton Keynes wide webinar program under our Children and People's program to update colleagues around long COVID presentations in children and young people. And we've got our local experts here today, so please feel free to ask questions. And colleagues who cannot attend today and you feel you still have questions, please, we will put an email in the chat box and you can send your questions to us so that we can we can get the answers, relevant answers back to you. We are recording this webinar again for colleagues who are not able to join today. We've got an excellent lineup of speakers, and they're all our local experts and developing experience and expertise around long COVID. So I will get our speakers to introduce themselves because I might not be able to do them much justice. Before I do that, I just want to introduce myself. I'm Sanita Chakrabarti. I'm a clinical lead for children, young people and maternity program across Bedfordshire, Luton, Milton Keynes, CCG and integrated care system. I'm going to hand over first to Andrew Potter, Andy, who runs our primary care assessment service. And over to you, Andy.
Thank you very much. Can you see that screen okay?
Yes, we can, Andy. Thank you.
Thank you. Thank you, Steve. So my name's Andy Potter. I'm a GP based in Milton Keynes. I've been a GP here now for 10 years. My background is in cardiology, so I'm also a GP with specialist interest in cardiology. For the last 12 months, we have been running from here the long COVID service for adults, but also children, for Bedford, Luton and Milton Keynes. This is a service where we are commissioned to do assessments on patients to rule out any evidence of organ damage or organ injury and refer on as appropriate to further management, so such as breathlessness management, fatigue management, or other assessments that might be needed. We have been referred over 500 patients, with some under 16s referred. So I'll talk a little bit about how the referral process, or what the referral process is locally, the sorts of things that might be seen in children, other bits that can help, and how GPs and local clinicians can help us. We agreed early on, and we continue to agree, to prioritise children as the numbers are fortunately so far fairly small. So we will prioritise triage and then a telephone or face-to-face assessment of young people suffering, and then refer onwards as we need to. So we define long COVID in adults as we do in children, where with new and ongoing symptoms 12 weeks after a confirmed or presumed case of COVID. This is how our initial definition, this is how we come up with an initial definition of long COVID for our clinic that started just over 12 months ago. The presumed case of COVID was in there initially because, of course, as you'll all remember, very early on in the pandemic, testing was infrequent and unavailable to quite significant numbers of the population, and we felt it was unfair to turn patients away who hadn't been able to access a test. So initially, we would accept patients who had presumed COVID. This always brings potential issues with accepting patients who may never have had COVID, but may have had ongoing symptoms before, but have pinned or attributed a lot of their non-specific symptoms to a vague illness around January, February of 2020. Now that's less of an issue because, of course, testing is so readily available. We are commissioned to see patients really with long COVID, so that needs to be new symptoms. Many of our patients have been referred in adulthood, and some in childhood actually have had these problems before, and maybe the clinician, the GP, has been struggling to be able to identify a cause or identify a clinic for somewhere for these patients to go. So some of these patients have been referred, but we've accepted them and triaged them and referred as appropriate. So in children, it seems to be uncommon. Now, that could be that it is uncommon, and out there there is low numbers of patients affected 12 weeks after COVID. It could be also that it is out there, but patients are unreferred. So it's either uncommon or unreferred, because we have not had large numbers through. We've had less than 10 under 16s referred now, out of about 500 in total. So it's a very small number. Now, that doesn't mean that young people out there are not suffering, but it certainly means that they have yet to be referred through to us. And of course, therefore, the point of the benefit of these sorts of webinars is to make clinicians and others aware that there is a process to be able to see children. We're not necessarily asking you to go out there and proactively seek them. I'm not sure how you would anyway, but I think it is important that local clinicians are aware that long COVID in children does cause problems for some, quite debilitating for others, and not many have so far been referred. One of the problems we've suffered with in the adult long COVID service is actually a huge number of unanswered questions, and this is because COVID is a new disease, let alone long COVID, and that's exactly the same, of course, for long COVID in children. There's a huge number of unanswered questions. There is research out there, and the CLOCK study is a large UK-based study with children and matched controls who have tested positive, mainly self-reported testing positive, and they've been followed up with self-reported symptoms, and that can sometimes give some epidemiological data on how frequent long COVID is in children and the sorts of symptoms that continue to affect children. The common symptom in children and young people, fatigue, as in adults, and actually I could very easily make this slide the same for adults in long COVID. So fatigue is a very common problem. Fatigue meaning severe tiredness that does not seem to improve with rest or sleep. And the common symptom is that they feel completely washed out, and despite having often quite significant amounts of sleep, are unable to get out of bed because they just feel so washed out and lacking of energy. Brain fog is a common symptom that coincides and that occurs with fatigue, and this is often described as patients as fuzzy-headedness, forgetful, word-finding difficulties, unable to multitask, which is a big problem if someone's at school or at college. Are clearly going to be a significant problem. Breathlessness, we've had patients referred with breathlessness, which is often an variation or a worsening of asthma. So young people with asthma more typically seem to become breathless. Dizziness and palpitations, with heart rate racing after very simple activities. So simply getting out of bed or standing up can cause significant palpitations and awareness of the heart racing. Headache's another common symptom that often coincides with dizziness, really. Some data from the CLOCK study, or an aspect of the CLOCK study, which is ongoing, where various constantly being analysed and reported on. A paper published not too long ago, which was a pre-publication, so not yet peer-reviewed, was that, again, self-reporting. Those young people that were self-reporting more prolonged symptoms are the older children, so 15, 16-year-olds, more likely to be female, and actually with a baseline of poor physical or poor mental health. And again, I could keep that slide or that sentence in for adults in our long COVID clinic. They're not older, but they're middle-aged, more likely to be female, and often have a poor physical and definitely a poor mental health. That is a common a type of patient that we see in the adult long COVID clinic as well. Interestingly, the CLOC study suggests quite a high prevalence, and we know that huge numbers of the population, children, young people, have tested positive. So we know huge. I've got my 11-year-olds at home today testing positive yesterday, and looking at the data and the evidence for the rollout of vaccines in younger people. The estimation is that 75% of 5 to 12-year-olds would have had COVID by the end of this sort of Omicron wave. So huge proportions of the population have tested positive. The CLOC study, which again is self-reported, suggests that up to 30% of people self-reporting are still symptomatic at 3 months. So there's something here where these symptoms are not being transferred onto or not being converted onto referrals to the post-COVID assessment service. And that might be because the symptoms are quite mild, maybe because then don't think that there's any help, so they don't go and see their GP, difficult getting into their GP, don't want to speak to anyone about it, and are just suffering in silence at home. But there's definitely a huge disparity there with the suggested prevalence, the number of people testing positive over the last 6 months or so, and the numbers that we are being referred. Now, of course, we're obviously the wave in the long COVID clinic peaks at a different time to the acute COVID test or positive tests, because we will only see patients at 3 months with ongoing symptoms, and of course we haven't yet really got to the 3 months since the particularly high rates in December and January. So we may find by Easter time we do have a wave of younger people being referred. The self-reported data again from this CLOC study did suggest that symptoms in younger people do tend to settle sooner than in adults. Working age, and particularly middle of working age, are probably the most common patients referred to our PCAS generally, and often it's that sort of middle working age that tends to be most severely affected and affected for longest. One of the very interesting things about the demographics of our referrals in our adults is often those healthcare workers and workers in educational settings, so particularly teachers, are extremely likely to be referred to our clinic, which is fascinating, and we'd like to do some more research into why that might be. Local pathway for this can be sometimes quite a specialised area is GP identifies a new and ongoing symptoms 12 weeks after a positive test. As I say, most of these patients have positive tests, and they can refer to us. We will prioritise these and offer them a telephone call or a face-to-face appointment. We will then do some basic assessments. We'll have access to the patient system on record, which has huge information, obviously, on all their background as well, so we can get a sort of window into previous GP consultations or previous assessments. And we'll offer a telephone call or a face-to-face with one of our GPs. We have nurses working in the clinic, but we tend to have one of our GPs sees the younger patients. And then we will either discharge, as we have with some, or if we feel there's more ongoing symptoms that could benefit from further assessment from the regional clinic, we have either the regional clinic in Oxford that covers Milton Keynes, or Addenbrooke's that covers Bedfordshire and Luton. Of course, as clinicians in Milton Keynes particularly, but I think also Bedford and Luton, we've never had access to any fatigue management clinic. So actually clinicians in our region have very little experience of being able to refer onto fatigue clinics, and probably therefore don't necessarily have great experience at knowing how to manage patients, young people in particular, with fatigue. So part of the benefits of being able to refer to these more specialised clinics, even though there isn't a specific treatment modality for long COVID fatigue, for example, well, actually, even getting these patients to a fatigue clinic is an improvement on what their offering might be potentially in general paediatrics or with their general practitioner. I've certainly never had, in 10 years, never had any of my young people referred to a chronic fatigue clinic. So it's tricky enough getting our adults into these sorts of clinics. So even having that experience, even though, as I say, there's no specific treatment modalities for patients with long COVID fatigue, then at least we have some expertise from those clinicians that have managed long chronic fatigue syndrome in the past. Our local expertise so far, our local experience is with very small numbers, breathlessness, asthma in particular. We can offer a spirometry, a pheno, another sort of breathlessness and respiratory assessment. Fatigue is a big problem. Loss of taste and smell, which is predominantly smell retraining. ENT do not really have much else to offer. Family factors are quite a significant issue that we've had. So it's important that you get an understanding when you're assessing these patients of not just the individual, but who's around them, because that will often give you several answers. The sorts of things that would help us as an assessment, so asking patients if they've tested positive in the past, if they might still be troubled if they're new problems. We like GPs to arrange blood tests most of the time, so we've seen lots of patients in our adult long COVID with low B12, low folic acid, low ferritin. Often if they're tired and in bed a lot of the day, they're just living on the teenage diet of beige, so sort of pizza, chips, chicken nuggets, rice, potatoes, etc. Products and it's not unusual that we've certainly found lots of adults with low B12, low ferritin, low folic acid because their diets dropped. Chest X-ray if there's chest symptoms, and then referral to PCAS on System 1. So it's a System 1 to System 1E referral. You simply go to the communications arrow, the orange arrow, the Ardens communications arrow under the patient demographics on System 1, and there's refer to PCAS in one of the tabs there, and we get the referral instantly. There's just some questions to answer. Another thing that would really help, there's a fantastic website with huge amounts of data called Long COVID Kids. Signpost parents to that, because there is a lot of support, and when you go into that website and start looking at the guidance and the information, you get a real feeling, and you'd hope that the parents would, that they're not alone, that there are others suffering like them, and I think that's really helpful. So that would be something that would help parents while they're waiting to be assessed by us. So blood tests, chest X-ray of chest symptoms, refer to us so we can assess and determine if they do need more specialised management, and ask the parents to look at, or the child or the young person themselves to look at longcovidkids.org, and it's a fantastic website. Okay, I think that's all I have to say at the moment. So if I will stop sharing my screen.
Thank you, Andy. That was really, really helpful. And it's really good to know the referral pathway into the PCAS service and what we need to do before. Any questions for Andy? I know we've only got Deo and Carol. Any questions? Have you got a question,
No, I'm
Deo?
fine, thank you. That was great, Andy. Very informative.
Okay, great. Deo, you got a question?
Yeah, it's more like a comment, maybe. Yeah, Andy, thanks for that brief but comprehensive presentation. Thank you. The question I was going to ask you is, on System 1, on the template, referral template, is there the link to the wonderful website you've mentioned?
No, I don't think it is actually. I'm sure Ardens would be able to put that on. It's very, yeah.
Yeah, because
it's quite an easy one to remember, actually. I think they've not made it to. Yeah, but no, I'm sure we can't amend the templates because they're Ardens owned, because I've tried. Yeah, I'm sure if someone at the CCG can ask Ardens to just simply cut and paste that URL onto that part of the template, actually. So on receipt of referral, we send out a letter to the patient with some information about our clinic and some other bits. So, you know, for the children, we add that into the letter as well. But actually, even before they get to us, they could start trying to look at the stuff.
So we will take that away, Andy, and we'll try and see if we could get onto the Ardens template. Thank you.
Thank you.
Great. Okay, dokie. So thank you, Andy. And Andy, I know you're on call and always grateful you could make time for us. So thank you very, very much. So Andy will stay around as long as he's not getting called. So next, may I introduce Dr. David Vickers, a pediatrician with long-standing experience around chronic fatigue, medical director for Cambridgeshire Community Services, and also part of the Addenbrooke's long COVID provision. But I'm probably not doing justice at all. So I'm going to hand over to David and get him to introduce himself. Over to you, David. Thank you.
I'm on mute, so let's start again. I was on mute there. That's just terrible, isn't it? So yeah, thanks. That you introduced me really well. So I'm just to emphasise that, you know, I've been involved in providing fatigue management services for young children, young people for the last 15 years or so. So I absolutely echo Andy's comments earlier about, you know, there's a group of children out there, chronic fatigue syndrome and other fatigue disorders, who do benefit from support from specialist services, and our specialist services run through Cambridge Community Services are available to children, young people who live in Bedfordshire, Luton and Milton Keynes, and we have seen a few children over the years from that area. So, you know, leaving aside long COVID, that service is available on our CCS website. But coming to long COVID, yes, I am involved with the regional service based at CUH at Addenbrooke's, which covers the Bedford and Luton parts of the BLMK patch. This is a new service. Just to explain what we offer a multidisciplinary clinic which takes place 2 times a month on a Thursday afternoon at the Child Development Centre on the Addenbrooke site. And that clinic, the team consists of a general paediatrician, myself and another community paediatrician who has a particular interest in children's mental health, an occupational therapist and a clinical psychologist. So we offer an MDT assessment. I think, like Andy, we have not seen huge numbers of patients, and indeed we haven't got huge numbers of children on a waiting list. And I concur, therefore, with the view that at the moment long COVID in kids is certainly not resulting in lots of children being referred to secondary care or into such service that Andy offers. I think there probably are quite a lot of children who've got mild symptoms which persist, but probably don't come not to the level which means they come to their GP or elsewhere for support. But the children we've seen have had quite significant symptoms. In terms of, Andy described really well the symptoms that children have, and I think it is that combination of fatigue, brain fog, which is really important, and it's important to ask about because often people don't tell you about it. It is that problems. It's not just concentration, it's problems with following what's going on in the classroom. It's problem with short-term memory. And that's a really important symptom for young people because, of course, it impacts their ability to access education. And I think to a lesser extent, we see children with pain, or often all over pain, as Andy described, the combination of dizziness and tachycardia, which often we call the POTS syndrome, and then a whole cluster of other symptoms, including taste and smell loss, nausea, weight loss, and really, as in adult long COVID, I don't think you see significantly different symptoms. It's really important, though, that we do screen those kids for other conditions, and generally the advice would be, certainly if children going to need more ongoing support, that they are seen by a general paediatrician as well to screen them for other conditions that might be causing symptoms. So we need to do that. And you know, as Andy said, in terms of management, it is the mainstay probably is managing those individual symptoms. It's looking at fatigue and offering a fatigue management program. And I think really importantly for children and young people, supporting them with issues around school access to education, and being really clear with their schools that they have got a medical condition that impacts their ability to attend school, and schools will want a diagnosis. So we need to be making a positive diagnosis of long COVID and explain to schools that this is a condition that affects children's ability to get into school. Otherwise, what we see is young people and their parents being pulled into meetings at school around attendance, and potentially parents being threatened with either with fines or prosecution for non-attendance at school. So it's very important we do make that diagnosis and give that information. I think the other thing we've noticed in our clinic is that by the time they get to see us, families often have quite a story to tell about what's happened to their child, and often quite a sense about why has this happened to my child? What have we done wrong? Because actually everything in the media would lead them to the view that children don't get COVID, or that's probably changing recently because children clearly are getting COVID. But if they do, they don't get it severely, and therefore they don't get the persisting symptoms. So often we have quite a lot of stories of guilt, about why me, and also often about not being believed there's anything wrong with their child. So I think, you know, it's really important we recognise those things and actually validate there is something wrong with their child. And I think also, for me, really important message we give out is, although we don't know much about long COVID, what we are seeing is that young people do recover. So we're seeing as young people go through their course of illness, that you see them improving. So actually we should be optimistic about this, because we do not want to encourage sort of long-term illness behaviour. So other than that, I mean, other than saying, you know, our team at Addenbrooke's are available for advice and support, as well as for referrals. So, you know, if people want to talk about children, we're very happy to be contacted. And I haven't got it with me, but I can certainly give the CCG team the email address for contact the team, so you can make contact with us if you want to discuss whether referral will be helpful. Because I think not everybody needs to come and see us, and what Andy and is doing with his local clinic, the local clinic, is absolutely fantastic. And actually, I'd hope that most young people can manage through that sort of service and through what primary care can do to support them. So I'm going to stop talking there, because I think, you know, the key message for me would be making a positive diagnosis is actually really important for children and young people. The worst thing we can do is continue to go round and round in thinking about what's wrong with this child. We need, if they've got a story which suggests long COVID and the screening investigations are negative, we need to be really clear about saying, this sounds like long COVID. What do we need now to do to support that young person to get better? And I'll stop there. Thank you.
Thank you, David. That's very comprehensive, and it's great to, you know, it's often that we don't have secondary care support, and it's fantastic that at least for this condition where we're still learning a lot, we've got expertise, multidisciplinary support that we can draw on for our children, which is really good to see. Any questions for David? So David, Andy, I've got one question, and that is around sort of the, oh, Carol's got a question. I'll get Carol to ask her the question. Carol?
Oh, hi there. Sorry, I haven't got my screen on. I'm a
That's
GP
okay,
in
no problem.
Woburn Sands, on the edge of Milton Keynes. Would you mind talking us through what the latest advice would be about kind of graded exercise and that side of things? Because my little bit of reading has been that that's gone out of fashion a bit and it hasn't been pushed as much. So I'd just be interested to hear.
So have you got half a day as the answer to that question in terms of talking about graded exercise? Because as you intimated, it's hugely contentious. If you look at the new NICE guidance on chronic fatigue syndrome, which is probably where you're coming from, it is really clear about saying graded exercise is not something that we would now be suggesting to patients in a routine way. And indeed, the very concept of graded exercise is probably no longer a reasonable thing to use. But I think what we would encourage, what we still do with patients, is to talk about the benefits that exercise brings, because actually exercise and increasing activity is core to what you do with fatigue management, which is actually finding out what your level of activity is that doesn't exacerbate fatigue, and then gradually increasing it. So we would now be talking about pacing, therefore approaching people's activity and gradually increasing activity, whereas the idea of graded exercise, which was actually you have an exercise program you follow and you increase, is no longer supported by NICE. It's been hugely contentious, and many patient groups have been vociferously anti any approach which incorporates exercise. But you know, if you're fatigued, and you don't do any activity, you will remain fatigued. People need to find an activity level and then gradually increase it. So I hope that's helpful. I mean, it is a really difficult area, and it's really difficult to get clear advice.
Yeah, that's very helpful, and maybe it's that change in wording as well that's helpful, because it just doesn't fit with exercise being helpful in so many other fields of medicine.
Exercise absolutely is helpful. I think graded exercise has got, I mean, if you go back to the thing, what was it called? I can't remember what the trial was called now, but there's a big trial looked at graded exercise, which showed some benefit of a formal graded exercise program, but probably only for some patients. And given we're talking about a heterogeneous group of conditions here, chronic fatigue and long COVID, there's a multiplicity of things going on here. It's not surprising that some people found that a formal exercise program wasn't helpful and others found it was. So really what we're doing is now saying to people, activity is good. And actually we need to look at how we can help you maintain your activity level and increase it. But we're not going to say, here, do 5 minutes a day on an exercise bike and then next day do 7 minutes. That's what graded exercise talked about, was that very rigorous approach. And that's what we no longer would suggest to patients.
Thank you, David.
That's helpful.
Thank you. Okay. The question that I was about to ask was the guidance around sort of when do you identify symptoms in a child and call it long COVID? Now, in adults, it's sort of quite specified, and it's 12 weeks and beyond, isn't it? Whereas in the children, I think if I read it correctly, that we probably want to know sooner. But any views on sort of when do we, at what point following the infection do we call some of the symptoms presenting in a young person as long COVID?
Well, I think it is 12 weeks, isn't it? I can't. I mean, you've caught me out there. I can't remember what the guidance currently says. I think it is 12 weeks, and the reality is, by the time children have had the infection, recover from it, and then realise that things aren't, maybe they're still remaining fatigued or symptomatic, and then they've gone to see a GP, you probably are at 12 weeks.
Okay.
When you think, but
okay.
I mean, what I would also say about one of the great things that we can all do is when we see people who've got persisting symptoms, is to give them advice about managing their symptoms right from the beginning. And like Andy, when we get patients referred to our chronic fatigue service, we always send them our patient information leaflet, which contains a whole suite of bits of information about managing fatigue, managing pain, managing concentration, etc., because actually that is general advice about how you manage something like fatigue, and none of which can be harmful because it's just general advice. And I think, if you see a patient who's fatigued, it's actually giving them access to the sort of advice about how do you manage fatigue is really useful, because often people do the wrong thing, which is they think, oh, my child isn't able to go to school. They're just, I'm going to make them go to school. And they keep coming back, the school keeps ringing up and saying they're feeling really unwell, they need to come home, rather than saying, actually, maybe we need to wait a bit and allow a bit of recovery. And then, so pacing your recovery against your symptoms, rather than forcing yourself to go back to normal and then finding you can't manage. So that early support about just saying, yeah, after you've had a nasty infection, you can feel unwell for a few weeks, and it may go on a bit longer. Self-care, that sort of look after yourself idea.
Thank you, David. That's really helpful. Andy, did you want to come on?
No, I don't think there's I think I echo all those sorts of points, really. It's certainly, we've seen with adults that it's such a varied condition, and it really does, management advice really does need to be tailored to the individual, of course, and that's what we try and do, and that's one of the benefits I think patients get from the clinic, is speaking to people that have spoken to other patients, and that feeling that they're not alone, and that this is, we've seen this before, and oh yes, we've had patients with this sort of thing, I think is hugely therapeutic. Actually, the service itself and the appointments themselves are I think are hugely therapeutic.
Thanks, Andy.
Yeah. And I'd agree. I think being validated is really important for this patient group. Actually having somebody say, yeah, we've heard that before, oh yeah, you're talking about this symptom. Yeah, we've heard that before. And that's just really important for people. Otherwise, people think that nobody believes me, and then actually, is there anything wrong? So I think that validation is really, really important, because actually, what people tell you sometimes is really peculiar in terms of their symptoms. They're outside of the sort of things that we see every day. So, the whole thing about fatigue is actually quite difficult for people who haven't experienced fatigue to understand what it feels like.
Great. Thank you, David. Thank you, Andy. Okay, if there's no more questions, we'll move on to our last guest speaker. And we are very fortunate to have Anita, who's our senior health psychologist and works within the Bedfordshire hospitals. Again, I will not do any justice by introducing Anita. So over to you, Anita, if you want to take over and introduce yourself as well. And we are so fortunate to have you. Thank you. Over to you.
Hi, hello, can everyone? I'm going to try and just share my slides before I start. Just quickly. Can people see that yet?
We can see part of it, but if you make it into slideshow, I think we should be able to see it. Yeah.
Perfect. Okay. All right. Just taking a bit of time. Perfect. Can you see that now?
Yes, we can. It's not on slideshow yet, though.
Oh, let's see. Sorry, I'm going to try one more time.
That's okay. Don't worry.
There, I think that should be it now.
So the presentation's gone off the screen now.
Oh, oh dear. And what I might do, if Simon is on there, he can, if he has Michael, I think he very helpfully formatted them. If he was happy to put them on, that would be great. But
okay,
yeah, absolutely, no problem.
Simon, yes, I think Simon would be able to do that for you, Anita. Then you can relax and do your talk. Okay, over to you.
Lovely. So thank you for asking me to join today. It's been really interesting actually hearing Andy and David talk earlier about the services that they have set up and led. So I'm Anita Durso. I'm a consultant clinical psychologist, and I'm actually outgoing lead of paediatric psychology services across Bedford and Luton hospitals. So there's somebody who's going to come into my post, but I've been working with Sunita and her team to develop paediatric psychology input into the long COVID posts across BLMK. So today I'd just like to talk a little bit about so the psychological impact generally of the pandemic on children and young people. So Simon, if you want to go to the next slide. Perfect. So again, Andy mentioned the CLOC study, and that's definitely one of the largest studies looking at just the impact generally of COVID on young people in the UK. But a number of studies across kind of internationally have looked at young people and how they've kind of managed the psychological impact of the pandemic. And kind of consistently there's been an impact on sleep in terms of how quality of sleep has generally deteriorated for most young people internationally, really, regardless of whether they've suffered from COVID or not. And as we know, sleep is often a precursor and also a symptom of emotional difficulties. So, for example, low mood and anxiety. And they found generally that there's a tendency for sleep to worsen in terms of quality. What we find is similar to what Andy and David mentioned earlier, was a group of patients who are particularly vulnerable, both in terms of long COVID, but also generally in terms of their emotional impact of the pandemic, are those who have pre-existing psychiatric symptoms such as anxiety and low mood. And that's particularly true, as Andy mentioned, for females and older adolescents. But there's also been a mixed results in terms of the impact of the pandemic on young people's resilience and quality of life. And many have showed that actually adolescents in particular demonstrated particularly adaptive behaviour and positive coping particularly during those early waves. And as Andy mentioned, the largest study in the UK looking at long COVID in children and young people, which studied over 17,000 responses. In terms of mental health impact, they demonstrated no significant difference in terms of mental health scores between children who tested positive for COVID versus those who tested negative. However, what was striking was that both groups reported in a large way, nearly 40% for both, feeling worried, sad or unhappy. and that varied from being a bit to very. So if you go to the next slide, Simon. So as we know, and we've heard, long COVID is a complex medical and clinical condition involving multiple interacting components, and we've heard already about the different physical symptoms that are often displayed by both young people and adults. And these physical symptoms can have a range of consequences, obviously, for the young person's body and their life. So it's harder for them to be physically active, and that can lead to physical deconditioning and potential weight changes. And those in turn can have an impact on young people's relationships, their independence, and that's particularly important for adolescents if we think about their the stage of life that they're in and how that impact of generally the pandemic, but also something like long COVID can have on them at a stage where actually their task is to become more independent and to kind of move forward with their life separate from their families. Actually being isolated, having to stay at home will have had a big impact on that. And something like long COVID will have another double impact on it because they might not be able to engage in the things that they enjoy or felt important to them. As well as having an impact on obviously education and hobbies. And a condition such as long COVID forces people to reduce or stop things that they enjoyed or which define who they are. So again, that task of adolescence especially is about developing their identity, who they are. And again, understandably, that in turn will lead them often to feel low in mood, kind of a bit low in response to having to adjust or make sense of long COVID. And also generally this feeling of anxious and feeling worried about their own health, the health of other people in their families, their lives and their futures. And obviously these psychological symptoms such as anxiety, worry, stress and low mood can have an influence on their day-to-day functioning and in turn make those physical symptoms worse. So for example, feeling frustrated and low in mood can make people less likely to persevere with things, or feeling anxious or worried can make them make it more difficult generally for people to problem solve. And then as we heard earlier, that can often lead to this kind of all or nothing cycle, so the boom and bust, which is where pacing, etc., can be really helpful to consider. Okay, next slide. So in terms of the psychologist's role in managing and helping to manage long COVID, it's thinking a little bit about kind of, I call it this kind of tiered approach to accessing psychological support. So very much in that bottom layer is developing kind of information and resources for all patients and families regarding the psychological impact and self-help material to manage this. And again, kind of that second tier, the structured rehabilitation and self-management, it's around psychologists being part of the structured multidisciplinary rehab packages, and kind of thinking about that, some of those cognitive symptoms as well that David mentioned, that concentration difficulties, memory issues. So thinking about kind of specialist expertise with liaising with those with education and strategies that education might need to do to help scaffold the environment so that young people can concentrate a bit easier and manage that a bit better. And psychologists across the country in these long COVID services for young people are providing this care through group work and kind of through psychological education to normalise symptom and explain causes, as well as provide emotional distress interventions and to increase confidence in and overcome the fear of resuming normal activities or things that young people had previously enjoyed and previously felt very important to them that they have stopped doing over time. And again, at the top there is kind of the more specialist support, which some young people will need, but not all. And that can be particularly important for those young people who have comorbid mental health issues, so kind of have clinically significant symptoms of depression, anxiety, or post-traumatic stress. So I've just briefly run through kind of some of the slides here, but I'm happy to take any questions. We're hoping that we can recruit a psychologist part of our team to work across the BLMK network to provide kind of support, psychological support for those with long COVID in the network. So thank you. And my last slide is just some references of some of the studies that I've talked about so far.
Thank you, Anita. That's so important, isn't it? And I think we kind of underestimate the impact that the pandemic and the lockdown has had on our children, who were kind of basically at homes away from their sort of usual networks, and we cannot even start to fathom the impact. So thank you. Any questions for Anita? Yeah. Okay. So Anita, thank you. And I was just thinking while you were talking there whether we need to take some of this information into schools and to sort of educate our teachers and give them much more information around this, because I think there is a lot of kind of anxiety there amongst teachers as well, not knowing what to do. And I know having the support would be really helpful from them, and some of your suggested support of things that people can do by themselves would be quite helpful. So so thank you. David, did you want to come in?
No, I just to say that was really interesting, and I'd just say I obviously, the psychological impact on young people of the pandemic is, only beginning to understand that, and certainly in our paediatric services we are seeing quite a large number of referrals, which the roots of which are the consequences of either not being able to access services during the pandemic, and therefore things have got worse. So young people were sacrificed for the benefit of those of us who are older, to protect. That sounds that's been dramatic, but actually I think that's how young people often feel. Actually, is that their needs were pushed aside by the needs of their grannies and their granddads.
Yeah. Andy, did you have a reflection? Oh, sorry, did you want to come in on that, Anita?
Yeah, absolutely. And I think, what Andy was saying as well about, those are, pre-morbid physical and mental health difficulties being more at risk. Actually, we know that generally becoming independent is more tricky for those families where they have children who have chronic health conditions, because they worry so much about them becoming independent. But actually, it's a critical task for them to be able to do in order for them to live fulfilling lives and to develop self-esteem that's kind of more optimal. But yeah, the pandemic has had a double whammy on those young people. So I completely concur. We've definitely seen huge increases in the rates of referrals of young people who have been struggling emotionally post-pandemic.
Thanks, Anita. Andy, did you have a reflection?
I think I think we're gonna continue to learn more, aren't we? And it will be very interesting to see what happens in the next couple of months. Really, it's the pandemic is very different now than it was 24 months ago, and it will be just interesting to see how people cope, and also the effects on sort of mass vaccination of younger people as well, the sorts of impacts that might have going forwards as well.
Yeah, I think there's more of us to learn. I mean, we're probably not even at the bottom of this hill. That I think that there'll be more that we will get to learn. But I think what you've all emphasized to us, and what is more reassuring, and having heard some national speakers talk about this, is that very few children are coming to us with sort of prolonged symptoms of fatigue and other issues following a COVID infection. Now, that could be they're not being able to get to us, or genuinely they're low, but I think the research is showing the numbers are low, and those who are getting some of the symptoms are recovering sooner, and that is again quite reassuring, isn't it? Because our children, young people have got their whole lives to lead. Yeah, thank you. Any further questions from anybody? I think we've come to the end of our time. It's been a huge privilege to have our local experts who've given up their time to be with us today to talk on this really, really important area. So may I take this opportunity to thank you, Andy, David, and Anita, for your fantastic work that you're already doing, and also sparing your lunch hour with us, which probably is not a lunch hour. I'm sure you've done some rejigging of your clinical work. So we are ever so grateful. Thank you so much. So if there's no further questions, I will close the meeting today. We'll send the recording out through our GP newsletter. Oh, Carol's got a question. Carol?
My only thought was I missed some of Anita's slides because I had a call came through. So I'm wondering if would you mind emailing them, Anita? That would be.
Yes,
Yeah.
I'm happy for them to be shared. So
because so Anita, what we quite often do with these is one GP from the practice will attend and then take it back to our clinical governance meeting.
Sure.
So if we have the actual slides, if people are happy, then we can show the slides and just talk it through, and that means it gets disseminated to a wider.
Perfect.
Wider
No
workforce.
problem. Yeah, so
That'd
when
be
we
great.
send out the link, we will also send out the slides.
Brilliant.
And if you don't mind sharing your slides with us as well, that'd be really great. So we'll send the slides and the recording, so colleagues who are not able to attend today can see that and listen to it as well. Okay. I hope that was helpful. Thank you very much, and have a great rest of your day, and see you soon. Thank you. Bye.
Thank you, everybody.
Bye.
Thank you, everyone.